Hey everyone, and welcome to this explainer. If you're prepping for your upcoming nursing exams, you are in the exact right place. Consider this your high-yield, structured study guide for chapters 10, 12, and 14 on geriatric care. Today, we're taking all that critical textbook data and turning it into real, actionable clinical judgment. But before we get into the heavy details, let's introduce our case study patient. Meet Arthur. He's a recent stroke survivor, and I want to see if you can figure out your very first clinical nursing action for him. Arthur has dysphagia, meaning he has difficulty swallowing. So what's the plan? Are you supposed to serve only pureed foods, maybe offer small sips of fluid with each bite, place food on his impaired side, or have him swallow twice between each mouthful? Keep this scenario in the back of your mind, because we're going to uncover the exact evidence-based answer as we analyze the core systems affected by aging. All right, grab your notepads. Today's clinical review covers 5 vital areas: nutrition in older adults, mastering the M&A tool, dysphagia, safe swallowing, geriatric elimination, and skin integrity. Let's kick things off with Section 1, Nutrition in Older Adults. We're looking at Arthur's baseline nutritional risks first because, honestly, nutrition is the foundation of healing and immunity, and the stakes are incredibly high here. Get this, 1 out of 2 hospitalized older patients are malnourished, and a staggering 50% are malnourished upon discharge. Now, this isn't just because they aren't eating enough. It's because aging physically changes how the body actually interacts with food. Physiologically, our older adult patients experience a decreased perception of taste, specifically those salty and sweet flavors. Combine that with a drop in saliva production, which leads to dry mouth or xerostomia, weaker chewing muscles, and slower gastric motility, you've got a perfect storm for undernutrition. For a stroke survivor like Arthur, this directly impairs his wound healing and completely tanks his immune response. So, how do we measure this? That brings us to Section 2, Mastering the M&A tool. To properly evaluate Arthur's nutritional status without just guessing, we absolutely have to apply the gold standard screening method. Clinical judgment relies on solid, standardized data, and that is exactly where the mini nutritional assessment comes in. It's beautifully designed as both a quick screening and a detailed assessment tool, looking at food intake decline, weight loss, mobility, and psychological stress. Assuming Arthur is over 65, this is exactly what we'd use. But here is the major caveat you have to remember for your quiz. The M&A is only valid for patients older than 65 years. You literally cannot use this on a 50-year-old patient and expect accurate results. It's tailored specifically to the geriatric profile to catch that malnutrition risk early. Now let's move on to Section 3, Dysphagia Safe Swallowing Interventions. We need to apply our clinical judgment directly to feeding Arthur because his stroke put him at a massive risk for aspiration pneumonia. Dysphagia is one of the most critical risk factors you are going to manage on the floor. And here is the absolutely crucial first step for any patient with dysphagia. Arthur must be sitting at exactly 90 degrees during all oral intake. This is your high or full Fowler's position. Gravity is your absolute best friend when you're trying to prevent aspiration. Before a single spoonful of food or sip of thickened liquid even comes near Arthur, you have got to ensure the head of his bed is fully elevated. Okay, so the key here is mastering this exact feeding sequence. We start at 90 degrees. Then, during the meal, you actively supervise and coach Arthur to alternate his food and fluid. Remember our opening quiz question? Well, here's the answer. The key intervention is that you must cue Arthur to swallow twice before the next mouthful. This clears any residual food and stops it from slipping down into his airway. And the intervention doesn't just magically end when the meal does. He has to maintain that upright sitting position for at least 30 and optimally 60 minutes after eating. That is exactly how you confidently prevent aspiration pneumonia. All right, shifting gears, let's look at Section 4, Changes in Geriatric Elimination. As we age, there's a natural loss of bladder tone and elasticity, which leads to some pretty complex challenges, especially incontinence. Now, you need to mentally organize your data to differentiate between the 6 types of urinary incontinence. Think about Arthur. He might experience functional incontinence. This means his urinary tract works totally fine, but a physical barrier, like his post-stroke mobility issues, literally prevents him from reaching the toilet in time. Contrast that with transient incontinence. That's a temporary leakage caused by an acute situation that will pass, like an active UTI or maybe a side effect from a new medication. Being able to correctly categorize the incontinence completely dictates your nursing care plan. So to actually address incontinence, you need evidence-based interventions. We aren't just managing the aftermath here. We're talking about active rehabilitation. You're going to want to implement scheduled voiding and prompted voiding programs to retrain that bladder. You'll teach pelvic floor muscle exercises, you probably know them as Kegels, to strengthen the sphincter tone. And absolutely critically, you must diligently assist and teach proper paracare to protect the patient's hygiene. Leaving a patient in a compromised state doesn't just destroy their skin integrity, it strips them of their dignity too. And speaking of protecting the patient's skin, that brings us to our final topic, Section 5, Skin Integrity and Pressure Ulcers. Did you know older adults account for 70% of all pressure ulcers? As we age, our skin becomes abnormally dry, and those aging blood vessels rupture easily from even the most minimal trauma. This is especially true if the patient is on blood thinners. Skin tears are incredibly common. If Arthur suffers a skin tear during a wheelchair transfer, you don't just cut away the loose skin. No way. Your immediate, evidence-based intervention is to gently cleanse the area with normal saline and then very, very carefully return that skin flap right back to its normal anatomical position. It acts as a natural biological dressing. You secure it, but never, ever use harsh adhesive tape on fragile geriatric skin. Okay, as we wrap up this explainer, I'm going to leave you with one final clinical judgment challenge based on wound assessment. Imagine you have a patient with an open sacral pressure ulcer. The wound bed is a pink-red color. You can't see any adipose, that's fat, and deeper tissues are definitely not visible. There's also no sloughing present. So, based on the fact that it's open but shallow, red-pink, and has no deeper tissue involvement, what exactly is your diagnosis? Is it stage 1, 2, 3, or 4? Think about your Braden scale. If you identified this as a classic stage 2 pressure injury, nailed it. Awesome job. But remember, treating Arthur isn't just about memorizing wound stages. It's about seeing the big picture, how his nutrition, his mobility, and his skin are all completely connected. So as you head into your exam, ask yourself, how are you going to integrate all these systems to truly advocate for your next geriatric patient? Good luck studying, and I'll see you next time.